So to start the day, is Rand here? Each moderator will be running their own session, and our first session is going to be run by Rand Simpson.
Okay, so bonjour, bienvenue à Paris. It's exciting to be here in this prestigious institution to begin the first workday, and to see so many interested people and smiling faces, particularly after last night. Paul has done an enormous amount of work to get this together, and as we know he can do, and it's just, I think, a great tribute to him that it has come together this way, and he's put all the topics in order, and he's suggested issues. Today is really going to be, I think, a great start to another initiative. The issue of registries, which we're starting off with, really has to do with the fact that everybody here is challenged always with trying to manage rare disease, rare cancer in the eye. And so that we're all aware of the fact that the foundation of this exercise really turns out to be classification, something that we can all live with, a standardization of what we do, and a common language. And so that registries really have to do with that. The concept that we'll run through this morning as well is the fact that there are ways to get at these registries and to produce them. The Canadian iceberg that you see here really has to do with the fact that we can hopefully obtain a lot of information from single centers throughout the world and have that information delivered to a database that then can modify what's there. And this can be done electronically with website issues that we're all aware of. And this is sort of the morning that we're going to talk about these various websites that we've been able to produce. It's a way of producing an enormous amount of material over a short period of time, which is going to be more and more interesting as time goes on. The staging systems that we've known about are, as you see, they've been extremely helpful over history. And some of them have been very successful. Some of them have evolved. We're trying to look at various styles of registry. The COMS worked for a while, almost for 20 years. It gave us the 6th edition, the AJCC, in essence. But it did have its problems. It had its problems in the fact that it didn't look at iris very well. It didn't look at the ciliary body involvement very well. That was confusing. And certainly the juxtapapillary melanomas were not included well either. So there were failures of the COMS, which we're all quite aware of. On the other hand, retinoblastoma has come a long way too with its various classifications, and Brenda will be talking about that in a little while, letting us know that the classification clinically is one way, and we're going to be pursuing that in terms of perhaps laying on top of that a way of pursuing patient care with classifications such as this, and have an ongoing, rather real-time look at a natural history of therapy. The universal staging system for the eye required in 2004 that the OOTF, the Ophthalmology Oncology Task Force, be put together and within 5 years come up with a 2009 edition, the seventh edition of the AJCC. It was a very heavy task, and it was a huge amount of work accomplished by many people in this room. The OOTF was to provide an anatomically based staging system with practice guidelines for clinical data collection, including pathology at that point. And evidence-based genetic and molecular biomarkers were to be included, even though they, at that time, perhaps weren't agreed upon, but we were to include that as well. The concepts, there's power in numbers, and you'll see this written and you'll hear it said throughout the morning. The fact that we can provide information from single centers throughout the world and deposit them in an area, in a registry that will collect all of that, and do it in a short time interval. And this is something that is rather unique in terms of what we're all about in terms of registry, that what makes a difference now. Eventually, the eye tumor-specific EMR will facilitate prospective and multi-center data collection, which we've talked about, and the database analysis will improve patient care, we hope, ultimately. These large databases are more powerful, and just the example of 10 centers with 40 patients per year providing 1,000 cases in 2.5 years, it's just something to think about in terms of the theme of what we're talking about now. The registry construction is not easy, and it takes special resources, special teams, IT teams. We're lucky in Toronto to have such a team. These people do all of what you see there, and there are resource implications to all of that. And that has to be looked at and has to be decided upon when we're deciding on where these registries should be located. Well, the first step towards change is awareness, and the second is acceptance. And has this been accepted? Well, ophthalmic oncologists and pathologists really worldwide have accepted this. And there is a list of acceptance in front of you. Over 12 medical journals now require the AJCC to be at least talked about or discussed in their manuscripts. So it is indeed accepted. The current and possible registries that we're facing, and we'll hear about this morning, have to do with what you see in front of you. Uveal melanoma has been completed in terms of its effect on validating the AJCC. The retinoblastoma is just on its way. Conjunctival melanoma is on its way. Vitreoretinal lymphoma has just been introduced in terms of a demo just a few days ago. Ocular adnexal lymphoma and lacrimal gland carcinoma and eyelid carcinoma are also well on the way. So that these are the diseases so far that have repository, as it were, in terms of database in Toronto at the moment. And so we'll be hearing about uveal melanoma, we'll be hearing about retinoblastoma, conjunctival melanoma, and from Sarah Copeland ultimately as well. We'll also be hearing from the lymphoma registry through Beta Ishmael and others. And we're going to be also listening to lid carcinoma. Orbit is going to be looked at as well and well on the way. The final discussion today will relate to systemic disease related to disease beginning in the eye, and we can also turn that around and have diseases elsewhere coming to the eye. And is this a registry that we want to look at? This will require another set of conditions, but it may be possible. So for consideration really today, the original concept of all of this in terms of the web-based aspect of it was that we were to validate what was already in existence in terms of the 7th edition of the AJCC. The validation was accomplished with uveal melanoma, but now are we to proceed with a prospective look in terms of our registries, and this is part of what's going to be discussed this morning. We need to look at limitations, we need to look at resources, and we need to look at how to look at novel therapies. How are we to include that? Are we to include that? And those are the kinds of discussion points that we'll talk about later today. Brenda will talk a little bit more about this too, because our aim is not only just to establish registries and classification to disease, but we also want to somehow allow real-time natural history of therapy with disease, to not only for education purposes, but to look at patient care in a broader sense. And eCancer Care does that. It's already been implemented for retinoblastoma, linking Canada, India, and Kenya. And the currency will be maintained through evidence-based looks as well. But I think Brenda will talk a little bit more about that as time goes on. So all in all, Winston Churchill has suggested that we be perfect. Well, we can't be perfect. However, it's a good start. This day is going to begin in that direction, and we hope that the talks are going to be short, at 5 minutes at least. And we have a water gun, as a matter of fact, I think, to make sure that happens. And the discussion is going to be the important part of this day. So we'll continue now with a second speaker. And the second speaker is going to be, yes, Svetlana Sakyana.
Good morning, dear colleagues. I'm very glad to meet you in Paris and in this famous institute, Curie. And today my presentation is dedicated to first result of uveal melanoma registry. During many years, different staging systems were used for uveal melanoma classifications. Staging is very important to determine diagnostic and therapeutic options and provides the international languages of patients' local, regional, and systemic status. In 2009, the 7th edition of the AJCC were created. It was the first widely accepted work, included 47 eye cancer specialists from 11 countries, and became universal. However, all cancer staging systems must be tested to determine the tumor prognosis based on the 7th staging. This all has determined the aim of our internet-based data sharing study, and aim is to assess patients' mortality outcomes associated with uveal melanoma staging according to the 7th edition. 10 ophthalmic oncology centers from 8 countries in 4 continents participated in this study, in which Russia took part the first time. Just our clinic, where every year we have up 300 new patients with uveal melanoma. The special protocol were created and the patient's data were entered online. This protocol you can see on the slide. This stage was automatically calculated, and the total of 3,089 patients with uveal melanoma were entered into the online database. And 181 patient entries eliminated because of lack of follow-up, and 67 of these had initial metastasis. Results of 3,377 patients entries were analyzed, and 3,217 patients from this with choroidal and ciliary body melanoma, and 160 patients had primary iris melanoma. Tumor sizes are demonstrated on the slide. Median follow-up composed 3 and 2 years. 25 patients died without metastasis, and 10% of patients developed metastasis. With use univariate analysis, metastasis was related to prognostic and anatomic staging. Here's patient AJCC staging, and stage 4 was excluded from the investigation. And the right columns is data of OG and to compare. On the slide, we can see 10 years metastasis-free survival, and we can see that in stage 1, the survival is 94%, stage 2A, 84%, and in stage 3B, 3C, only 24%. Kaplan-Meier analysis of metastasis-free survival in 1, 5, and 10 years after the treatment in different stage of uveal melanoma, you can see in slide. You can see that the survival had the survival had patient in all stages. And Cox regression model results risk of metastasis demonstrated that patients on stage 2 and higher had significantly higher risk metastasis development compared with stage 1. One 5-10 years survival based on tumor size classification, TNM system, was also calculated. It was shown that increasing tumor size was associated with an increasing risk of metastasis. And here is survival of patient according to presence or absence of ciliary body involvement and extraocular extension. Univariate analysis suggested this category is associated with an increased occurrence of metastasis. The worst survival were revealed in patients with ciliary body tumor and extravulvar extension. Iris melanoma was diagnosed in 160 patients. The number of patients with metastatic iris melanoma was too small to assess mortality risk according to stage. Metastases were revealed up to 3%, almost 12 years follow-up, and all patients in stage 2. And in conclusion, we can say that this study validated the 7 edition AJCC staging for ciliary body and choroidal melanoma. There was a statistically significant increased risk of metastasis for each increased T stage, and as well as the presence of tumor ciliary body and extraocular extension. Multi-center worldwide internet-based data sharing is feasible in ophthalmic oncology and decreases the impact of single-center selection bias by providing a more heterogeneous patient population. And last, you can see where recently published this data. And special thanks to Princess Margaret Cancer Center Coordinating Center, Christine Messi, statistician from PMCC, financial support from the Eye Cancer Foundation, Inc. and John and Myrna Daniels, and special big thanks to Paul Finger. Thank you, and thank you all.
Thank you, Svetlana. And the next discussion will be Brenda Galli, who will talk to us regarding retinoblastoma issues.
Thank you very much, and thanks, Paul, for this amazing meeting and wonderful dinner last night. It was superb. I'm going to talk about retinoblastoma, go back in history, but first of all, I must thank Tran Trong, Yulia Gavruk, and Justin Liu. Yulia and Tran are here somewhere. Where are you? There they are. They are two representing the Health Informatics Research Group at PMH, who's put together all of these registries, or surveys as I'm used to calling them. And they're tirelessly working. They don't mind being harassed at all. They respond quickly to all sorts of crazy things, and they're amazing people. So take time to meet them. So I'd also like to point out that this room is a very, very important room for retinoblastoma. In 2003, Laurence hosted the International Society of Eye Genetics Disease and Retinoblastoma, as it's still called. And in this room, the whole room, about this number of people, agreed that a single classification was useful. And I'll jump forward in that. So retinoblastoma is the most complicated cancer to stage because you've got two eyes. You've got up to 10 different primaries between the two eyes. Each eye has a different aspect. The normal eye of unilaterals alters how you would treat the other eye. And you need to score, when you're scoring whole patient outcomes, you need to consider one eye as the index eye, the best eye or the worst eye at diagnosis. So it's a very complicated disease. So from the after the 2003 meeting, we set out to do a world survey of classification of retinoblastoma, comparing the Reese-Ellsworth to the Murphy 2000, what we now call NERF in 2005, but at the time we did the survey, it was just the Murphy ABC classification because it had not been published at that point. And this was the result of the 2003 meeting, and I have Murphy's slides presented at that meeting. He'd worked for about 10 years on developing this classification with multiple input from everyone around the world at that time. And you can see scoring quite a few children, 1,400 children and XIs. Where I've put the X's here, that's where they become too close. They don't distinguish in the Reese-Ellsworth, and the 5B and 5A actually overlap, etc. So this is not an ideal classification because it doesn't clearly separate into finite groups that would then lead you to propose an appropriate therapy for that stage of disease. Whereas the Murphy IIRC did separate them quite nicely at that time. This was the DIs because all group E were enucleated as E was meant to indicate. And so now we have it doesn't turn off. Now we have 5 different eye classification schemes here because after Murphy published in 2005, Carol Shields published another version in 2006. Then the Children's Oncology Group published another version which changed small things in 2008, I think, and TNM came out in 2009. So we have a whole lot of different classification schemes. So what we set out to do now is to compare those. This is the first look at what they mean. Here we include 4 of them. We didn't put the Ellsworth into this schema. And you can see for A and B, they're essentially all dependent on focuses. They're pretty consistent across A, B, and maybe C. So all of them basically map out the same features. All the features you need to score any of these are incorporated into this list of the data input. But the algorithms underneath the database calculate each stage separately. But you can see there's a major difference in size of tumor. So Murphy and the others pay no attention to overall size of the tumor, whereas the Shields IIRC considers any tumor that's greater than 50% to be an E. So that means that a whole lot of I's are E's that in the other groups would be D's or C's. And the features for E in the Murphy are the features that very clearly point to, not counting visual potential, but point to risk for extraocular disease, risk that the tumor is already threatening to move outside the eye or already has. And that signal of high-risk pathology, which you can only get on pathology by looking under a microscope, in other words, if you take out the eye, then you actually would give some portion of those children adjuvant chemotherapy. And the data from many, many publications and different centers would suggest by giving that chemotherapy, you might save children's lives. But you won't know to do it if you don't have the eye to look at under a microscope. So the database that we have built now to do this staging looks like this. We're now recruiting centers, and I'll show you data from the first 3 centers that have entered sufficient data to put it together. And it's very simple. Online, you merely score different features. The minute you said distance from fovea and select, you'd get a drop down and it would give you fixed choices. There's no data entry. It's all fixed choices, and then that data is used to calculate the different stages. And you can see in this particular eye, because this tumor is greater than 50% and less than 2/3 the volume of the eye, it would score that right eye by the Murphy IIRC as group D and by the Shields as group E. So that illustrates the point of that major difference. So this is the results of the first 388 patients entered from 6 centers, but there's really 3 centers whose data is the substantial contribution to this particular very preliminary analysis, because we would expect to have many, many more centers and many, many more patients involved in this survey. So here's the Ellsworth, 2006. Again, you see this crossover between the groups 5B and 5A, which are seeding or very large tumors. Here is the Murphy 2005, published in 2005. And you can see it's got pretty good separation of A, B, C, D, and E. And there's only 6 E's because we've eliminated from this analysis any eyes that were enucleated primarily because they scored as E. They were enucleated in order to get accurate pathology. But in this analysis, there are 6 that were actually treated. So what we're measuring in all of these curves are failure is the failure-free progression, and failure in retinoblastoma is quite standardized to be removing the eye or giving external beam radiation. That's a failure point. That's what's been used for the last 20 years. But I think today moving forward, we'll need to change that failure definition at some point. You can see in the Shields modification of the IIRC that the C, D, and E all lump together. And that's because there's a bunch of eyes there that would be scored E here, that are moved up and become D. So here these E's, or rather the other way, these would be E's are sort of contaminated with D's. So there's fewer D's and more E's. And that's why they fail to separate in outcome. The TNM separates out T3B, has 8, and so it's pretty much equivalent to the Murphy E. And again, size doesn't matter in the TNM. So today we are moving forward, and this is only preliminary data. I think we should throw away all of these names of classifications and forget everything we've done before and look at the raw data of the features of the eyes that are collected in the database and let the algorithms to build a whole new classification which accurately predicts and separates groups. I would suggest that just on the basis of the artistic quality, 5 groups is pretty nice because it sort of separates, but as soon as you get into too many different features, it doesn't separate so well, so the data becomes more cloudy. So that's just a suggestion. Moving forward, what we propose, and Rand referred to this, next steps, to have a world registry. Actually, I'd like to bring up the subject of registry. I'm not quite comfortable with the use of that word. What we are doing in retinoblastoma and the melanoma was a survey, a fixed time interval, a fixed window to collect outcomes on the patients that were there. A registry is a continuously ongoing thing that collects data. Usually, the registries have collected very small point numbers of data fields because that was all they could manage. And today, of course, you can have all the data you want, and you don't need to worry about having too much data. So our model for retinoblastoma is based on eCancer Care. This is an illustration of a child with bilateral retinoblastoma. This is her staging EUA, the red line. If you pointed to that on the computer, you'd get to the date, immediately would show up, and then you'd double click and you'd go right into all the details of that day, of that visit, including the pictures and the pathology and everything that happened associated with that event. And then you can all see that she had 12 cycles of chemotherapy. That was way back a long, long time ago. She's 20 years later now has useful vision in both eyes. These are focal therapy. So, and the genetics was done quite a few years later because that's when the genetic test was ready for this bilateral patient. So you know all about this patient in one glance at this output. But the data comes into this at the point of care, tremendously helps the doctor caring for the patient. And in Toronto, we're still running our patient care on version 1. You're looking at version 2, which has been running in Kenya for 3 years, but very much as a registry, not as a point of care, and that's the next step. So once we have point of care databases like this collecting data everywhere, and in the retinoblastoma, it's going on a cloud server, which Tran promises will be up next week. In Toronto, it'll be sitting in Toronto, but it will be everywhere in the world. And then underlying all that data, which is identified fully for the point of care, but completely de-identified in analysis, then there'll be little engines running around and algorithms underneath that so that the next child that comes in, the features are entered at the staging EUA and the treatment options in the context of where that child might be and resources, et cetera, all come up for the doctor to pick what the next optimal care is. So that's my vision. So I'm already 70 years old. I'm going to live 30 more years because I'm going to see this through to completion. Thank you.
Thanks, Brenda. There'll be lots of room for discussion at the end of this session, and the next speaker will be Stefan Hegard. And He will be discussing octocnexal lymphoma registries. We're just pulling it up now. You're ready to go. If you want to go, just, is he so?
Good morning, everybody.
Do you have a pointer?
No. Can I borrow it? So I would like to give you the experience of dealing with ocular nexal lymphomas for a registry that has been working for several years now. So this is mostly the highlights of this, and as one of the slides that Paul made, that there's power in numbers, that I'm going to substantiate this. So we looked at all the ocular nexal lymphomas for 7 eye cancer centers from this huge period. In my country, we are very good in registries and go very far back. And these are the centers that were included. And by doing this, this was possible to have all this information of all of our patients. I'm not going to go into details, but of course survival here is very, very important. So this is the distribution of close to 1,000 ocular nexal lymphoma patients in the different centers. So you can see we have 2 American centers, 3 American centers, 1 Australian, 1 Indian, and United Kingdom, and our own center. And by doing this, we got this distribution of ocular nexal lymphomas. So we can see that mortal lymphomas, extranodal marginal cell lymphomas are the most common ones. And again, we can see that there's power in numbers, so we are able to see the overall distribution of our lymphomas. And we could substantiate and see and look into different subcategories. We're able to say what are the most common symptoms in this group, what are the clinical signs, what is the location of the ocular nexal lymphomas, where is it mostly localized or predominantly localized. It's possible for us to differentiate within the different groups. And again, you can see here, we could put all these data in our subcategories. And importantly, by doing this, we're able to see what lymphomas should have what kind of treatment. And it's also possible for us to see what is the overall survival of all lymphomas, and being able to differentiate also within the different primary cancer centers. And by doing this also, we can see what are the differences in the world, how we're treating ocular nexal lymphomas in our part of the world in contrast to other parts of the world. And again, you can see the survival curves of all these different lymphoma subtypes. So this is the overall. If you want to go deeper into research, it's possible to do microRNA due to we have this vast material. And what is the outcome of all this? So we published this in the Archives of Ophthalmology, where we looked at diffuse large B-cell lymphomas. We published this, another multi-center international study. And there are 2 more articles underway. And this leads to the last slide, that we do find that it is highly recommendable to perform these multi-center studies. It is extremely hard work, meaning that it's hard to get the data from all of these contributing centers. It's extremely important to say and find out what the task of each center should be. And you do need to have all the data from all these centers. By doing this, you can publish your articles in high and good quality journals, and there's going to be a high scientific production, and it provides good spin-off. So thank you very much for your attention.
Thank you, Stefan. The next discussion will be from Dr. D'Amato, who's spent an enormous amount of time looking at conjunctival melanoma and producing a survey with the Toronto database as well. But Bertil, we're looking forward to this.
Good morning. Congratulations on organizing such an event where we're not only speaking about things but actually doing something about them. And we've developed this registry for conjunctival melanoma, and I'd like to acknowledge the great work of the team in Toronto. We're not as far ahead as the lymphoma group. We're still at the stage when we're testing the registry, and what I'm doing at the moment is trying to break it, trying to find problems with it, trying so that they can be remedied at this stage. So far, we've had 116 patients submitted from a small number of centers. Several centers said that they did not have the bandwidth to enter the data, and so we have to address that problem. And you can see that the mean age ranged from -1 year, so we need to validate the data in some way to make sure that date of birth is entered correctly and date of treatment and so on. The system works well with the data. The registry works well. One of the problems is that different centers did things differently, so that some centers only entered positive results and others entered positive and negative results. So if there was a blank, it meant different things in different centers. So that has to be fixed. And we also need to define better what is meant by different terms regarding invasion and extent and so on. The current TNM staging system uses quadrants, bisecting the caruncle, 12, 3, 6, and 9. And the problem with that is that if you've got a tiny tumor straddling a junction between two quadrants, you have a tiny tumor affecting two quadrants. That greatly exaggerates the apparent extent of the lesion. So much better to work in clock hours. The problem with clock hours, if you've got 2.5 clock, if it's from 2:30, then it gets difficult even statistically and so on. My preference is for minutes. I've been using clock minutes for many years, and I find that really simple statistically and so on. And then there's the histology, and that's fine. And one of the problems is that the TNM stage is calculated automatically by the registry, but if there are blanks, which in some centers mean no, then that automation doesn't work. But if I assume that blanks mean no, then my own calculation of the TNM stage corresponds very, very closely to the automated system. One of the problems with pathology is that it needs to be integrated better with the clinical findings. The clinical findings look at the clinical TNM looks at for instance, the basal diameter of the lesion, but not the thickness. With the pathology, we should try to work more to look at thickness and to integrate that with basal diameter. With regards to the treatment, I was able to extract the data and to order the data and so on, but it wasn't easy to see whether it was a primary treatment that was administered or a treatment for a complication, or whether it was the institution that actually gave the treatment, or whether the treatment was performed elsewhere before the patient was ever seen. And those are things that need to be clarified. So we need to know the reasons for the treatment. So treatment dates weren't always completed. I have to make sure that that's completed. And also, with regards to outcomes, there's more about treatment. With regards to outcomes, we had a median follow-up of 52 months. 14 patients died, but only 2 died of melanoma. If we're going to do any statistical analyses, we need many more deaths than just 2. So if we've got 118 patients now, we need 1,000 patients in order to look at lots of predictive factors when it comes to death. With regards to outcomes such as recurrence and so on, the current system, I thought it was going to give dates for the recurrences and other problems, but the registry doesn't quite do that. But that's going to be modified so that we don't just know whether there was a recurrence at the last follow-up, but we would know whether there was a recurrence a year previously or 2 years previously, and so on, different stages of follow-up. And that's very important to be able to look at dates of recurrence, dates of visual loss, dates of metastasis, and things like that. So another problem that we found was that the patients were anonymized. So when I got back in touch with a center to rectify problems, the person who had entered the data wasn't able to link the data in the registry with the patient, because that person very assiduously followed the rules, totally anonymizing the patients. So it's very important to pseudo-anonymize the patient, and for each center to have a file linking the code number with the patient's name and hospital number, so that they can go back and rectify problems and so on. So I noticed that PTIS disappeared, and we need to have that back. And so in summary, this has been a very useful preliminary study. We've learned a great deal. We've managed to extract data, do analyses, but we need more patients. Several centers say they don't have time to enter the data. If we can somehow provide assistance with that, then we'd make more progress. Thank you very much.
You brought up some very good discussion points, which we will talk about shortly. And so our next speaker will be Sarah Copeland. She'll be talking about vitreoretinal lymphoma, which we were just able to get out as a demo recently. She'll talk about that as well. Thanks, Sarah.
Thank you very much. I'd just like to reiterate and emphasize the huge amount of work that Paul has put into organising this day. I've not only had telephone conferences with him regarding this, but also regarding the 8th edition of the AJCC, so multiple juggling of multiple balls simultaneously. So thank you very much. We've heard already about the ocular adnexal lymphomas, and in the 7th edition of the TNM, that was the first time that a TNM staging system for ocular adnexal lymphomas was drawn up. And you heard the validation study from Stefan Hergaard. So we're looking at vitreoretinal lymphomas and whether we can actually consider devising a TNM staging system for this. The registry for this is very much in an embryonic stage. The beta version was only released 2 or 3 weeks ago. So ocular lymphomas, as you know, deals with both ocular adnexal lymphomas and intraocular lymphomas. We've spoken about the ocular adnexal lymphomas. When we're talking about the intraocular lymphomas, they can be subdivided into the vitreoretinal lymphomas, the choroidal lymphomas, and rarely the iridoid lymphomas. And these are the subtypes according to the WHO lymphoma classification. When we're dealing with a proposal for a TNM staging for the intraocular lymphomas, we're really only speaking about, at the moment, the vitreoretinal lymphomas, which are the high-grade B-cell, predominantly high-grade B-cell DLBLs. So as you know, this is a highly aggressive disease. It's increasing in incidence in both immunocompetent and immunosuppressed populations. We don't understand why this is occurring. There is an association with CNS disease, and unfortunately the majority of the patients do develop CNS disease, and it's a result of this that they succumb and pass away. So how the problems are associated in recognizing this disease, both clinically and also confirming it histomorphologically. How do we do it in the lab? This is usually as a result of receiving an intraocular or vitreous biopsy, or sometimes a subretinal aspirate, or indeed chorioretinal biopsy. And then we do the cytospin, we do the immunocytology. Some prefer to do the flow cytometry. And then also, particularly here in Paris and also in Bethesda, there is the analysis using cytokines looking at interleukin 6, 10, and interferon gamma. We tend to use IGH-PCR, which is a clonality analysis looking at the B-cell population, and recently we described the presence of MYD88 mutations, which are present in approximately 80% of these tumours. So when we consider staging of these tumours, you're essentially, and I don't want to be telling you as a pathologist what you usually do, but you obviously do a complete ophthalmological examination, both eyes. You do the CNS examination, CSF tap, and more often than not, the oncologist would like to have a systemic analysis looking at the full blood count, liver function tests, bone marrow trophine, and also potentially serological testing for HIV. Treatment varies considerably across the world, and this is a summary from Janet Davis's paper, and whereby it outlines the different treatment methodologies across the world. And I think this is a common phenomenon for rare diseases, that they're treated differently. And when we compare what staging is undertaken for CNS lymphomas, it's pretty much the same. Not in all centres do they actually consider looking in the eyes, but they also they exclude a systemic non-Hodgkin lymphoma by doing the staging, and it seems to be pretty much routine that HIV testing is done. They've come up with prognostic parameters, and these include liver function tests, age greater than 60 years, and these are 5 adverse risk factors which they've listed. And if there's this paper by Andre Ferreri, Journal of Clinical Oncology, which suggests that if you have between 1 and 5 of these adverse risk factors, then you can determine the prognosis of the patient. So how do we collect the information on vitreoretinal lymphomas, since it's such a rare disease? Well, I think the way forward is via this registry. It is the beta version, and this has been put together, and Julia and Tran have already been mentioned through the tremendous amount of work, and I think this is the 7th version that has gone back and forth via emails. Unfortunately, it's very pale here, but that was, I can show you in higher magnification, all the information that we're hoping to capture for all of these patients. And this includes the clinical characteristics, the treatment, and various, also the pathological parameters, how the diagnosis was confirmed, and also the treatment and the outcomes. Sorry that it's so pale here, you can't really see. We're going to finalize this beta version. We're going to circulate it ASAP. We would very much like people who are involved in contributing data to let us know. At the bottom are our email addresses, and we'd very much welcome as many centres as possible taking part in this collection of data, so that we can come up with, I think, an overview of how people are diagnosing the vitreoretinal lymphomas, how they're treating them, how they're possibly staging them, and how we can possibly put forward a TNM staging system. And this obviously would be together with the neurologists and the neuropathologists who are also going through the same motions in considering a staging system for the CNS lymphomas. So thank you very much for your attention. Please don't hesitate in getting in touch with us.
This is one of those gaps that we talked about, the audiovisual issues. We're done about 5 to 8 this morning, and so we've had a little bit of difficulty in getting that put together. To put a meeting like this on from arm's length from North America to here with the Curie Institute closed over the weekend had some issues. So we tried to rectify that this morning.
Plug in her laptop?
Yeah.
No, it's okay, it's okay.
You found it now?
Yeah, yeah. Beat that?
The top one. This one? Yeah. Uh-huh. Okay.
Okay.
Yes, thank you very much. I want to first echo what Sarah said. Paul, thank you for your leadership for organizing this. It's just tremendous work and much appreciated. It's going to lead to many important collaborations. So the database that we have had at MD Anderson is sponsored by the American Society of Ophthalmic Plastic and Reconstructive Surgery. I think it probably, time flies. I think we probably started to work on this about 4 years ago. I do need to acknowledge ASOPers because they did give some symbolic financial support to this database, and I think, but more importantly, they gave their support so that the membership can use it and participate. So this is for oculoplastics and orbit surgeons. So the focus really was on orbit and adnexal cancers, although some of the intraocular tumors that do happen to present to oculoplastic surgeons are also captured in it, and they can be captured, not to duplicate the effort that was shared earlier today that have large-scale intraocular tumor presence. This particular database is for orbit and adnexal, but we do allow oculoplastic surgeons to also enter their intraocular tumors that they may come across. So as has been shared earlier, the primary goal is to gather and disseminate data for rare cancers, and it's a multi-institutional database. It is housed at MD Anderson just for logistic reasons, because one center has to take on the role of designing a database and maintaining it in terms of security. So that's the role that we have played, different participating centers gain access through VPN client. This is a highly, highly secure server at MD Anderson. And I think much of the work that needs to go into this, I think Bertil made the comment, it's not so much entering data that takes time. It's all the legal steps prior to that is very, very time consuming. Partly I feel bad about not participating in the conjunctival melanoma database, but the reason is we have been so labor intensive on this particular database. Each center has to go through many steps that is very time consuming, but once they get on board, it's incredibly easy. And they enter their data. We don't do it for them. They enter data into a secure database. So, but I said that this is sponsored by ASOPers, but by no means is it exclusive to ASOPers members. It is definitely open to members of various different groups, ASOPers, New Zealand, Australian colleagues. I think they have an interest. It just requires some planning, and certainly members of ISOO are welcome to participate. It is based on the 7th edition of AJCC, which is the most recent published version, because we very much want not just the usual demographics, but we want to classify the tumors as they are entered. So the current database is designed based on 7th edition, but it has the capability to be modified as we publish the 8th edition and the 9th edition. It can be updated. The data design people at MD Anderson can do that very easily. We designed it with that in mind, that it has to be updated every so often. And then we have these data capture sheets, just from a logistic, practical standpoint. As you are seeing patients in the clinic, busy clinics, ORs, it's not easy. Well, it's much easier to capture the data as you go, as opposed to having to go and retrospectively try to collect the data. So we have these I call it intake sheet. Maybe you can call it it's a raw data sheet that we have distributed to various centers, and you can sort of do this little bit of practice of classifying your tumors. It also has been very helpful to me in terms of understanding the nuances of AJCC. Once you actually, from a practical standpoint, start to use this classification, you'll see the strengths and the weaknesses. And I think it has really helped our discussions for polishing and refining AJCC for the 8th edition, because only in using this as a clinician are you going to find the problems and also the strengths, the areas where it's really, truly very powerful. So so then in two or three pages, you can really capture all the I think it's 8 chapters, I counted, 8 chapters in AJCC dedicated to ophthalmic tumors. So in 2 pages, you can capture all of them in a kind of a summary fashion. And this is what we encourage the centers to use. And then you can, once a month or once a week, depending on your manpower, you can sit there and enter it into the database. That's really not that hard to do once you have done the basic work. To remind you, there are AJCC classification for lacrimal gland carcinomas, orbital sarcomas, ocular adnexal lymphomas, which I kind of put in the orbital and adnexal variety, eyelid carcinomas, conjunctival carcinomas. So all of these can be captured in this database. And of course, these are the 2 main limiting factors in terms of time consumption. So every center has to have an IRB-approved protocol. This is absolutely required in the United States to even participate in a database. So we have a universal protocol that was first approved at MD Anderson, and I just distributed to the various centers. They put it through their IRB. Various different IRBs have different requirements. So at our center, we were allowed to enter both retrospective and prospective data. At several other universities in the United States, that has not been granted. So mostly they enter prospective data and have to consent patients. So each IRB has their own specifications. And then the second piece is this, I call it the legal piece, is a data share agreement. So this is, our legal office spends quite a bit of their time setting up material transfer agreements, data share agreements. But once they do one, then it's rather routine. So we so far have done this with 11 centers, and it's been over the course of 4 years as it's unfolding. And this really, at least at our institution, and I believe in the United States, is the only way to do this in kind of a legal way. Not legal, whatever it is, a compliant way, compliance with various different rules. So far, 11 centers we have. They're all from the U.S. so far, but I really very much would invite other centers to participate. Mostly prospective capture, as you will see. I have the ability to put all my patients in, but I just haven't had the manpower to go back to 17 years of being at MD Anderson, having somebody to go sit there and classify every tumor. So far, our data is limited to prospective, but we can someday, I hope to, get a motivated fellow to come and do this with me. It would take much of their time. All orbital, eyelid, conjunctival, and trochlear tumors can be entered, as I mentioned. We also have a category for orbital surgeons. We have a category of other orbital tumors because there are many, many fascinating rare tumors in the orbit that are not AJCC classifiable, but we want to capture them. So they are fair game. Also, we have a category of other relevant oncologic conditions. That would be, for example, a unique side effect of a cancer drug you're interested in. You can still enter those. As of June of 2015, earlier this month when I queried the database, we have 1,165 patients that have been entered. This is the breakdown. Now keep in mind that, so as expected, the most common is carcinoma of eyelid. And then, interestingly, followed by other orbital tumors, which is actually, to me, is not surprising. But keep in mind that many of these numbers are low. For example, sarcoma is only 16 because we have not had time to go back and do retrospective data entry. But these can be enriched, these numbers can be enriched very easily with some additional time spent. So, but I'm optimistic so far with this, and there's some areas of overlap with some of the other databases, which I think we should try to combine, but the problem is this MTN IRB business that really is very time consuming. So we so far have generated some studies. None of them have been yet published, but in various different stages. The eccrine carcinoma of eyelid was led by University of Iowa, Aaron Shriver. I think it's almost ready to be submitted as a paper. The rest of them are in various different stages so far. Metastatic or eyelid basal cell carcinoma, rare, but there's actually a fair number. So in terms of future for this particular database, of course, we have an interest in additional centers to enter. I hope that I have motivated some of you to come on board. And the steps that are necessary are not impossible. It just takes a few months to get it off and going. But entering data is not the worst part. It's the preliminary steps for the IRB and MTA. And then, and of course, we do need to modify the database with each edition of the AJCC. And I hope that someday the information in this particular database will contribute to refinements for the 9th edition. In the discussions we've had, led by Paul, for various different AJCC chapters, we are constantly faced with lack of evidence-based, lack of data. And I think that this type of thing can help us with the next edition to actually be not just using our impressions and what we think is right, but based on actual published data. Thank you.
So we've talked so far this morning about AJCC, essentially related registry, etc. It may be time now for discussion regarding ongoing issues such as metastases from the eye to the system, and maybe even from the system to the eye. And we're going to have a discussion by Anna Pavlik, who will talk about that for this morning, and then we'll start our general discussion after that.
Thank you and good morning. And as a new invitee to this meeting, I wanted to thank Paul for inviting me. I've had the pleasure of being able to work with Paul for the last 15 years at NYU. And so we decided to present this topic this morning with the possibility of developing a metastatic uveal melanoma tumor registry. And so again, why have a registry? The answer is because so many of our patients become metastatic. We don't understand why. We don't understand why they go to certain organs. Granted, the highest precipitation of tumor is always within the liver, but we also have patients who present with bone lesions, subcutaneous nodules, and lung lesions. Most of our patients with metastatic ocular melanoma are excluded from cutaneous melanoma registries as well as cutaneous melanoma trials. And so trying to find things that work for these patients is exceedingly limited, and there's little data as to what's truly effective. The natural history, we look at patterns of metastasis and progression. We try to determine the relative efficacy of methods for detection. Do we do PET scans? Do we do MRIs? Are MRIs, in fact, better at detecting small liver mets? And we need to be able to record and publish not only our successes, but as well as our failures. Because I think, unfortunately, many of us, because this is such a limited number of patients, will do multiple different attempts to control these tumors. There's really never been good documentation of really what works and what doesn't work. And I think, at least in my perspective, the biggest issue here is the lack of clinical trials in this area. Granted, the more that we learn to know about the genetics, we may be able to get more targeted therapies in order to address clinical trial information. And the question now with immunotherapy is, can we harness the patient's immune systems as we do with cutaneous melanomas to be effective for these tumors as well? Advantage to this is, unfortunately, these patients don't do well, and so their survival is usually 16 to 18 months, and so data can be accrued very quickly. What are the benefits? Well, we'd like to collect tumor, serum, and clinical data to make it a completely unified database. The reason that I proposed collecting tumor, serum, and clinical data is that we've done this already at NYU for our cutaneous melanoma patients, where it's a prospectively collected database where we get tumor, serum, and patient data we get the patient data and the serum every 3 months. Once patients are registered, we then continue to have this database updated on a regular basis every 3 months with respect to clinical data and serum if patients are coming in. We've got over 10,000 patients currently enrolled in our tumor bank, and we've got matched tumor specimens as well as serum and clinical data, which has really been very useful for us moving forward in proposing new clinical trials. We need to be able to formulate or abort new clinical trials, again, based on this data that's collected. So much of what we do in melanoma for ocular melanoma is truly based on hearsay. Again, What works and what doesn't work needs to be validated. We need to identify and coordinate large numbers of affected patients for the known mutations. Again, this is an exploding field. We need to be able to collect that data, and since all of these patients are required to get biopsied, whether it's liver or lung or bone, we will have tumor and we can run these mutations, and again, as a consequence of knowing these mutations, hopefully be able to target therapies for them. Identify patients that have tumors amenable to novel therapies. Again, some of these patients with subcutaneous nodules will also have accessible tumors, so we can not only get a tumor biopsy at the beginning of therapy, but also biopsy it during therapy as well as at the end of therapy to be able to see if we actually hit our target and how do we actually impact this tumor. And again, the goal in all of at least medical oncology is really to be able to identify biomarkers for a high-risk population. In addition to the ocular genetics from primaries, are there things that we can measure in the serum to predict who is at high risk and, in fact, who will recur? So how do we get started? I would like to propose an open multi-center international model. I'm sitting here totally astounded by the number of registries that all of you have been successful in creating and accruing to. Clearly, kudos to all of you for such a unified effort. I wish we in medical oncology were half as efficient as you were. Again, how big? Again, it depends on how many people would like to participate. Data fields and the ECRFs will clearly be generated by consensus, online forms. This can all be done online. And again, the informed consent and privacy templates will be distributed. And again, to reiterate that there's power in numbers, again, because this is a relatively rare disease, we have to work together in order to generate this information. Medical oncologists in general, there are very few of us who actually have the ability to see patients with metastatic ocular melanomas, and therefore I think this is the proper forum to present in order to try and generate a tumor registry. And like I said, there's only a few cases, but it's the people in this room who can truly make a difference when it comes to metastatic disease as well. And again, I want to thank you for the opportunity to present this idea and potentially work to create a new database. Thank you.
Paul's given us 10 minutes for discussion. And I think it's evident from what we've heard this morning that we've moved from validation of disease and classification and staging really to prospective looks in terms of a registry, and so that we've all maybe had a chance to look at some of these questions that you have in your program. And before we start that, is there any burning questions that we'd like to ask before we get into that sort of discussion from what you've heard this morning? As I say, we have about 10 minutes and maybe 15 if we're very good. We've been a little over on our presentations. Yes, Sarah.
I just want to make a comment that I guess one of the aims of these registries is to collate as much information as possible with various aims, but also to help improve the 8th edition of the TNM staging system and to validate what's already been put in place with the 7th edition. And I think in each of the different tumour chapters, we're at differing stages. So probably the uveal melanoma is the most advanced chapter. And I think it can be, I think we should congratulate ourselves that, putting the first 7th edition together, over 3,500 data points were collected for that, and then in the initial cohort, and then we've validated using another cohort of over 3,500. I don't think there are too many such rare tumours that can collate such amount of information through this multi-centre collaborative effort. Perhaps on the other end, we have chapters like the conjunctival melanoma, which does need a significant reworking, which I think was highlighted by Bertel, but the group that's working on that realizes that there's information in there that really needs to be updated, and I think the registry will help us improve at least the 8th edition and hopefully the treatment of the patients. So I think we're getting there with each of the chapters, but they're in different stages, and these registries will help improve them.
Yes, Kate, yeah.
Thanks very much. Could somebody comment on what happens if you're entering intermittent data? So I've heard somebody talk, I think Beta was speaking about retrospective versus prospective data. Because you're trying to collect as much as you can, if you don't have all the data points over a time period, can you still be entering out of a center, or does that contaminate what's collected?
Maybe I mentioned retrospective. I think I mentioned retrospective versus prospective. At least for most IRBs, that has to be clarified. So each center is going to have those rules, whether it's retrospective or prospective. So at least our database for the adnexal and orbital tumors, we're not asking for survival data as a data entry point up front. So the staging information should be readily available at any point that you enter a patient. But in terms of survival data, any study that is generated from the database will have to then, people would have to go back and get that information at that particular time point. Is that what you're asking? So which part is it? Which part are you asking? If it's not survival.
Paul? No?
Having been leading the writing group for the uveal melanoma section, which is the most mature of the registries, I can tell you that it's good. My feeling is the cure would be to have as many patients as possible, because when you go back through the database, you may not be able to use every patient. But there's no selection bias in that other than the fact that the data wasn't put in completely. So you can go back, and if we have 10,000 patients and 7,000 sets of records are usable, that's much better than anything else that we could find in the literature.
Yes.
It seems like most of the registries have a relatively small number of centers at this time, and the goal is to have many centers. I've worked a lot in multi-center clinical trials, and I've always been amazed at the number of errors we create, us physicians, in filling out the forms for the multi-center clinical trials that our study coordinators bring back to us to fix. It takes money to have somebody look you over the shoulder and make sure that the data quality is accurate. So how do you intend to ensure good data quality as you move from the most highly committed individuals that are paying a lot of attention to a widespread, a larger number of centers with perhaps slightly or increasingly slightly less committed individuals, and the creeping data entry errors that will happen from that, which are wide known in all data entry aspects of computing.
Brenda, do you want to? And maybe Yulia can talk about that too.
Yes, in the cancer care surveys that we've done, you can go back at the center that has the code that, by the way, has kept, and it's perfectly expected that you would keep the keep the identifier in the center, in a locked box, in a locked room, in a locked hospital, etc. But that's the only place that you can link to the patient. So you can add follow-up data at any time, and that just changes. You put in the date of last visit, you re-enter and change that, update that, or you put in that the patient died and give the date, and that's the accurate data. But on the retrospective data, you can do that on an ongoing basis, so it's retrospective and prospective. But also, in terms of data accuracy, the data at the bedside in the OR when you're doing the UA on a retinoblastoma child is the most accurate data that could be there. So that's why the moving forward, where the clinical care is managed in a database that is connecting right through to the quotes registry on an automatic basis without you doing anything, no transcription at all, is going to give the most accurate data, I suspect. But Beta, if you're not collecting outcome data at like even
Not at baseline anyway. Yeah.
But you are collecting. You're asking the clinician to stage, to give the check the box of the TNM staging. Mm-hmm. But then you don't have the raw data of the clinical features that resulted in that reading. So isn't that a place for error too, where the doctor could check the wrong box and make a mistake, but you can't check that because you don't have any real data.
Really, really good question. So I think if I understand correctly, TNM classification at what point? So when I think in most papers that are generated on TNM, so metastasis, for example, would have to be at presentation, right? You have to define what, I think that's what you're getting at. In other words, metastasis only becomes clear over time. So the M category for most of these tumors would not be readily available at baseline.
I have no idea. Because I didn't do
In the
beyond,
database, we've got,
beyond
for
us.
example, in
I think
retinoblastoma,
it is.
we ask what's the size of the tumor, how close is it to the fovea and the optic nerve, is there glaucoma, and which kind of glaucoma is it? And so you get, that's the raw clinical data. We don't ask anyone to classify. They don't determine if it's an A, B, C, D, or E tumor. The database then takes that data and generates all of the classifications from it. So you have the raw data. So now going forth to the 8th edition, we can go back to raw data. We can forget all the classifications and say, what does the raw data tell us we should classify for a new classification? No, I can, but you're only asking the doctor to say it's a T2A. But you don't know in your database why he said it was a T2A. You don't know what the features were. So that's a loss of data. And it makes an error-prone thing because maybe he didn't do it right, but you don't have a way to check that.
I hear you. Partly it's because it's so complex. For an eyelid carcinoma, for example, the definition of T2A, so we would have to get them to not only describe the size, but give a picture. I mean, if you really want to take it to that level, maybe you have with uveal melanoma, and it's a good suggestion.
But that's partly why the conjunctival database is hard to build, because
we
we're
need
building
to
it to be
shorten
able to do it.
this discussion. Otherwise, our next session will not go on. Taro, for 2 minutes.
Oh, no.
Taro's usually brief.
Yes. A very interesting property of data is that if you collect data, you can only generalize to an identical population.
Whenever you wish.
And to me, for that reason, you don't need to have perfect raw data, because in the clinical practice, you don't have perfect raw data. So if you base your classification on data that reflects what people are actually collecting, it may work better than if you have pristine data that is absolutely without any error. And regarding what Brenda said a minute ago, we've done, during the last 2 years, 2 studies of uveal melanoma in a subgroup of patients in the European Ocular Oncology Group. And we asked both the raw data and the TNM staging by the submitting investigator. And out of the European ocular oncologists, they misstage about 10% of their cases. So when we compared our staging from the raw data that we know to be correct, there was about 10% misconception of staging by the submitting institution.
So thank you very much for this discussion. And I'm afraid that we will also